Good afternoon. Welcome to today's webinar. We'll give everyone just a few more minutes to join and then we'll begin. All right, we're going to go ahead and get started. Welcome to today's webinar. My name is Carrie Rutia, and I'm an Oncology Outreach Coordinator with the Samaritan Cancer Resource Center. We are so excited for today's webinar on the topic of advancements in radiation oncology. Before we get started, let's go over a few virtual housekeeping items. Today's presentation is being recorded, and the recording will be available online at a later date. We're using the universal mute button, so please use the chat box in the right-hand corner to ask any questions. We will be monitoring the chat box throughout the presentation, and as time allows, we will answer any questions at the conclusion of the presentation. I'm pleased to introduce our guest speaker for today. Norman Yeh is a board-certified radiation oncologist with Samaritan Health Services. Dr. Yeh received his undergraduate degree from Purdue University and a graduate degree in immunology from Indiana University Medical Center and his medical degree from Indiana University. Following an internal medicine internship at the Naval Medical Center in San Diego, California, he completed his residency in radiation oncology at the University of Colorado. His clinical interests center around optimizing radiation therapy outcomes and appropriate malignant and benign conditions. All right, so without further ado, welcome Dr. Yeh.
Thanks, Kara. Let's see. Yeah, thanks for coming today. Good morning, good afternoon. I'm excited to talk about advancements in radiation oncology related to breast cancer. I have no disclosures. So today we're going to talk about benefits and side effects of radiation therapy for breast cancer, general radiation oncology, advancements, and a lot of the advancements have been to decrease side effects and increase convenience. So we're going to talk about some of these, including techniques such as deep inspiration breath hold, which can decrease radiation to the heart, omitting radiation in low-risk women, such as some women over 70 years old, decreasing the number of radiation treatments with hypofractionated breast radiation therapy, and radiating just a part of the breast instead of the whole breast. And so for breast cancer radiation, the first question is surgery with a breast surgeon to see what might be more appropriate, either a lumpectomy or a mastectomy. After a lumpectomy, radiation is often recommended. After a mastectomy, radiation is often not recommended unless there are risk factors. To try to make it more relevant, I have a made-up case to try to apply some of these principles. And in this case, this would be let's say a 72-year-old female with a small breast cancer in the left breast. She has seen a surgeon. She has decided for a lumpectomy. After a lumpectomy, it turned out to be a type of breast cancer called invasive ductal carcinoma. It was a small size, maybe 1.5 centimeters. On examination, she didn't have any lymph nodes in her armpits. So sometimes the breast cancer can go from the breast to the lymph nodes nearby, such as the armpit, before going to the rest of the body. And she did not have any of those lymph nodes. She had certain markers, such as what we call an estrogen receptor and a progesterone receptor on the surface of the cell. And so these were present or positive. There was not something called HER2 in the middle of the cell present. And this particular combination is just a good combination. It was a grade 1 tumor out of 3, meaning how much it looks like a cancer, from less like a cancer grade 1 to more like a cancer. I think the point is that all of these factors are low risk factors, and so hopefully she has a low risk of recurrence after lumpectomy. But sometimes we do recommend radiation after a lumpectomy because radiation sometimes decreases the chance of the cancer coming back, the recurrence risk, and possibly breast cancer specific mortality. So sometimes people ask if the cancer is removed by surgery and there's nothing left, then how does it come back? And possibly it's because there might be 1 or 2 cells left behind nearby where the cancer started or somewhere else in the breast, and radiation can possibly kill these microscopic tumor cells or tumor cells that we can't really see with the naked eye and can only see with a microscope. And this was shown in a trial around 2002, just one example. A group, the NSABP, published a trial, the B06 trial. And here is the figure from the trial, just showing that after surgery or after a lumpectomy, years after surgery, and the chance of the breast cancer coming back in that breast. In the white triangles, the chance of the breast cancer coming back after a lumpectomy at about 20 years was almost 39% in this trial. This was reduced to about 14% with radiation therapy. And so radiation decreased the chance of the cancer coming back. Sometimes we round these numbers a little bit from 39 to 13% might be about a third of 39. So sometimes we say that radiation decreases the chance of the cancer coming back by about 2/3. I think in the 10 or 20 years since this trial, these numbers have gone much lower. The chance of breast cancer coming back is much lower, but I think the benefits of radiation still remain. And again, just talking about some of these risk factors. So we try to see how aggressive a cancer might be after surgery with some of these risk factors. And so this is just a partial list of some of the things that we look at. So the size of the tumor, if it's larger, there might be more of a chance that it leaves behind 1 or 2 cells. If it has gone into the lymph nodes, it's a higher risk cancer as well. Kind of the hormone status, the ER, estrogen receptor, progesterone receptor, and HER2 status can help us determine how aggressive a cancer is. How much it looks like a cancer. If the margins are positive, we're more suspicious that cancer is on the if the margins are positive on the specimen that's taken out, we're more suspicious that it could be positive on the tissue remaining in someone's body. And age as well is a risk factor. In this case, an older age, and this might be related to menopausal status and the amount of hormone in the body, can be a risk factor that an older woman comparing apples to apples with the same size tumor and maybe no lymph nodes and the same status. Let's say, for example, a 70-year-old woman might have, we would say that that cancer might look a little less aggressive than the exact same cancer in a 30-year-old, for example. And after so that was after a lumpectomy. Again, after a mastectomy, typically radiation is not recommended unless risk factors are present. And so from that list, some of these factors would include if the lymph nodes turned out to be positive, if the tumor turned out to be larger size, such as greater than 5 centimeters, if the margins were positive. In those cases, radiation after mastectomy may increase overall survival, as seen in older European trials. This is a figure from the Danish 82B trial showing that with a older chemotherapy regimen at 10 years, the addition of radiation increased overall survival from 45 to 54% when some of these risk factors were present. So radiation so in a patient like this, or in patients in general, radiation can sometimes decrease the chance of the cancer coming back, possibly change survival. And so in this patient, we would look after the surgery to see how it looked. Again, most of these were low risk features, and go from there. To talk about the steps of radiation treatments. And a lot of people also ask exactly what is radiation therapy, and radiation therapy is like high energy X-rays that are used to kill the cancer. And the steps of doing that would be kind of the practical steps. The first step would be what we call a CT simulation session. That it's a CT technical details, and it simulates the treatment position. In this case, the arms are raised over the head to get it out of the way of the radiation beams when they treat the breast. They're holding on to some handles for comfort. The patient is lying on their back. We also do 3 small tattoos, each one the size of a freckle, to help with laser localization and setup. We would take a CAT scan to map the radiation onto, and in this CAT scan, there's some reference positions on the bottom here. Sometimes they're oriented where a person is kind of laying on their back and their feet are out of the screen and their head is into the screen, and a cross section through their body, versus when they are standing up and looking to the left in cross section, or standing up and looking forward in a cross section. So in this cross section where they're lying on their back and cross section around their chest area, the breast is shown in this area. The white is the bone, so the ribs here is the white. The black is air or lungs, and heart is here. And we would use this image to make a radiation plan. And so we would use this image to make a plan for radiation to treat the whole left breast, for example. In this picture, it's just showing radiation dose levels, and radiation is kind of like ripples on a pond, where it goes to our target and then falls off slowly with distance, although it is still fairly precise, where our distance is measured in millimeters. In this case, there's a lot of colors, but the red here just represents 100% of the radiation, where the yellow represents 105% of the radiation, and the green represents 95% of the radiation. So, so when we're trying to get 100% of the radiation in this picture, a lot of the breast gets 5% more than we want, 105%. And so while we're talking about advances in radiation oncology, one advancement is just in terms of previously this was done with X-rays, and now with CT-based planning and planning advances, we're able to still get 100% coverage in the red here and minimize the amount of yellow or the amount of hot radiation that we don't want to hopefully decrease side effects. We just say that the dose is more homogeneous. The plan is made and then sent to a radiation machine where is shown here, where the energy for the radiation is generated, and then it comes up through this kind of a C-arm and is directed out of the head here. And a patient is lying on the table here, and the C-arm can rotate in a circle here. The couch can rotate in a circle on the ground here, somewhat hopefully demonstrated in this picture, where a person is lying on their back. The radiation is generated out of the head and towards the patient. And I stopped it here because in breast cancer treatment, the radiation is directed kind of from this angle to generate a beam towards the breast in this fashion. Then the machine head continues to rotate, generates another beam from this angle to hopefully treat the breast and avoid things on the inside, such as the lungs and the heart. If you were to lie on the couch and look up at the treatment machine head, you'd see that there are some, we call them leaves in the head that are made of lead. These lead leaves can block and shape the radiation coming out of the head to help us form a radiation shape to just treat the breast, for example, and avoid the heart is one example. And this just shows that the leaves can move in and out. In this case, the leaves are moving out to create a more open radiation beam. Sometimes people also ask, how exactly does radiation kill cancer, the high energy beams? So this is just one slide about radiation biology, that a normal cell has DNA as its building block. And if radiation causes damage to one of the strands of the double-stranded DNA, typically a normal cell has repair mechanisms and can fix itself and hopefully remain healthy. For cancer cells, however, they often have defective repair mechanisms. So when radiation causes the damage, they are not able to repair themselves. And when they try to divide into daughter cells or grow, they die, and the body cleans them up, kind of like a scar on your skin. Okay. And then this is just a little bit of terminology, is that radiation dose is measured in a unit called a gray, and it's used a metric system as well. So sometimes we call it a centigrade or gray. And each radiation treatment is counted in fractions. So if we give radiation all at once, sometimes there's more side effects. So we break it up into little bits over a long time. This is one example dose where its total radiation is 50 gray, broken up into 25 fractions or 25 treatments. So each treatment is 2 gray. This is given, the same dose is given 5 days a week, Monday through Friday, to the same area to add up to the total dose, 50. For breast cancer treatment, for example. This is fairly quick. Usually I tell people that time in the department is maybe 10, 15, 20 minutes in and out the door. But there are a lot of treatments, for example, 25 in this case. And as the radiation builds up, it can also cause side effects. In the short term, it can cause people to feel tired, kind of like being out in the sun all day, just a little worn down, and can also cause skin changes. The skin changes are very variable or case by case. Sometimes there's no or minimal skin changes, and if we treat other times, such as after a mastectomy, sometimes it can cause a more moderate or severe sunburn kind of reaction that typically improves with time. Radiation can also cause swelling in the breast, causing some soreness. These hopefully improve in the following weeks or months after the radiation treatments, but sometimes there can be some side effects in the months or years after radiation is given. These could include changes in cosmesis. Usually this is fairly mild. Swelling in the arm or lymphedema, or damage to the nearby organs such as the lungs and the heart. This is just one graph from a paper by a researcher named Dr. Darby in England, just showing that the more radiation the heart gets here, the more the risk of major coronary events. In the next slide, we're going to try to show ways to decrease that, and I think we can decrease the radiation to the hearts to minimize this risk. I also include here as side effects of radiation as time. For example, the 25 treatments or 5 treatments a week would be about 5 weeks, and healthcare costs. So a lot of these advancements are to decrease side effects and increase convenience. So we're going to start with the deep inspiration breath hold. In this case, again, it's trying to decrease radiation to the heart, and it takes advantage of deep breaths. So here are some CAT scans. Again, the orientation is below, where a person is lying on their back in a cross-section through their body, or they're kind of standing up and looking to the left in a cross-section, or standing up and looking forward in a cross-section. And maybe if we look at this panel, we can see that the black lung, when there's a deep breath taken in, there's more space around the heart here. So there's more black lung here, or normal lung around the heart. In this orientation, I think I'm looking at this area right here between the heart here and the breast or the chest wall, that during a deep breath, there is more lung in between the heart and the chest wall. And this is just another way to look at it. During a deep breath, there could be more space between the heart here and the breast as well. And how exactly we do it is I've taken a video from the company website to demonstrate the equipment. Is that there is a mouthpiece that's connected to a machine that can measure breaths in and out, and then some goggles that can also give instructions. So on the inside of the goggles, during this procedure, a patient sees a waveform that instructs them to breathe in and breathe out, in and out, until they're ready to take a deep breath, and they continue to take a deep breath in. This deep inspiration breath hold, or DIBH, is also used for lung or liver cancers. This is an example from lung cancer, but the same principles are for breast cancer, where during this deep breath hold in the green area here, radiation is turned on to treat the cancer for a brief time, and then during the breath out, radiation is held. So radiation is only given when there's a deep breath. And then there's a rest period, and then it continues until the full dose of radiation is given. This is just another example of how it helps us create more space here between the heart and the breast. The white represents where radiation might go, and with normal breathing or free breathing, the heart is a little closer to the chest wall, so it's a little bit harder to avoid the heart sometimes. During a deep breath, there can be more space, and it's easier to for the radiation in white here to avoid the heart and treat the breast at the same time. So just some of the benefits of the deep inspiration breath hold is that it decreases radiation to the heart. It also decreases the percentage of the lung that gets radiation and decreases overall radiation to the lungs. It also decreases motion, and when we're trying to target something for radiation treatment, decreased motion allows us to have better targeting, and it possibly allows us to treat a larger area. And maybe very, very briefly is that sometimes more evidence has shown that if we treat some lymph nodes near the breastbone here, that may or may not have a benefit. And if we do treat those lymph nodes, sometimes we overlap with the heart, and deep inspiration breath hold allows us more space where we can treat a larger area and avoid the heart at the same time. So again, in this case, is a 72-year-old female with the small left breast cancer. She decided for lumpectomy, has low risk features. Going on to the next slide, we would discuss another advancement is in the past 5 or 10 years, they've tried to determine a low risk group where maybe radiation doesn't have enough benefit, where the benefits might not outweigh the risks. So they've chosen as their risk group women over 70. And this is just one of the trials that I was going to go a little more into detail, just step by step, that it was a trial that included small breast cancers. So the tumor stage 1 just stands for breast cancers that are less than 2 centimeters. The lymph nodes were negative. The estrogen receptor was positive. So again, these are all just good risk factors, over 70 years old. And I'm not going to go over all of it, just perhaps part of it, that radiation was given. Again, this is 25 treatments, or about 5 weeks to the whole breast. Sometimes we give radiation just to where the tumor used to be as a boost, and so they added another 7 treatments just where the tumor used to be. And there was a lot of women who had a lumpectomy, and I didn't say so much before, but for estrogen receptor positive breast cancers, sometimes endocrine therapy to block the estrogen can help. That sometimes the estrogen can be like fuel to the fire or to feed the breast cancer, and some of these medicines can block the estrogen and help. So in this trial, after lumpectomy, about half the patients received this endocrine therapy called tamoxifen to block estrogen, and the other half received tamoxifen with radiation. So it was kind of without radiation and with radiation. Without radiation, they found that at 5 years, the local regional relapse, or just the chance of the cancer coming back, was about 4%. With the addition of radiation, it decreased the chance of it coming back from 4% to 1%. And this continued to increase at 10 years to 8% chance of coming back, again, reduced by radiation to 2%. There's a lot of ways to look at it, and some people can look at it and say, if it's an 8% chance of coming back, then perhaps it's a 92% chance of not coming back, which is pretty high, versus 98% chance of not coming back with radiation. But I think the point is that overall it's a fairly low chance of coming back, and perhaps it's such a low chance that it did not change survival. So at 5 years in this group, the survival was 86%. The addition of radiation, even though it changed the amount that the breast cancer came back, did not have an effect on survival. And perhaps that's due to if the cancer came back, we would expect it to possibly come back where it's near where it started, and may be eligible for another surgery to treat it if possible. Would be one scenario. So their conclusions were that the rates of local failure or the rates of cancer coming back were possibly acceptable without radiation treatments for small cancers that were estrogen receptor positive, did not have lymph nodes in women over 70. Just another brief slide about some of the evidence shows that this is the trial we just looked at. There was about a 4% chance of coming back with hormone therapy or tamoxifen. This was decreased to about 1% with the addition of radiation.